Good evening to all. Myself, Dr. Krishneshwari, Assistant Professor, Department of Practice of Medicine in Aiapget, Kottayam. First of all, I thank the administrators of Focus for giving me this opportunity, and I am going to deal with rheumatology. So, what I am talking in the session is based on the Davidson 23rd edition. Everything what I say is in Davidson, the new edition, 23rd edition. So the thing has been changed since NEET has been introduced, and Davidson is considered as a standard textbook. And every time the question varies. We cannot say. There are some authentic questions which were asked from many years, for many years, but now the scenario changed. And what happened is every time the pattern of the question is changing. And we cannot go beyond along only with this MCQs. So what I have prepared is today I'm going to discuss about something regarding the basic anatomy and physiology, which is given in the Davidson, and also basic lab investigations, and also some regarding the basic symptomatology in rheumatology. And in the next class, we'll be continuing in the next sessions. So what I have done is I have prepared some MCQs from the Davidson, which I found important. And what I will do is, along with the MCQs, I will be explaining the options so that it will be easy for you. And you will be covering 1 to 2 pages of Davidson within one MCQ. That is what I supposed to do. Okay, so we will move directly. So first question. The long bones are formed. Long bones are formed from endochondral ossification. So according to the formation, depending upon the formation of bone, it is divided into two: long bones and flat bones. Flat bones means bones of the skull. Long bone means our ordinary bones such as tibia, fibula, femur, etc. So long bones, it is formed from endochondral ossification. And regarding the other options, intramembranous ossification, it is in concern with the flat bones. Flat bones are derived by intramembranous ossification. Endochondral ossification leads to the formation of long bones. Chondral. Chondral means you all know. Chondral means cartilage. So long bones are formed from the endochondral ossification, from the cartilage. Flat bones, it is derived from the intramembranous ossification. That is, it is derived from the mesenchymal tissue. Then C. Option regarding option C, growth plate. What is growth plate? We all know that epiphyseal end consists of the remnant of the bone formation, which consists of osteocyte, and it is responsible for the lengthening of the bone, growth plate. And the collagen ossification. Regarding collagen, we all know that collagen is a protein, and collagen is responsible for the structural structure of our body, formational structure of our body. And the most important thing we should remember here is there are two types of collagens, which there are so many types of collagen. Of this, two is very, very important. One is type 1 collagen and type 2 collagen. Please take a note of this. Type 1 collagen, the most important collagen present in the bone is type 1. Type 1 collagen. And the most important collagen which is present in the articular cartilage is type 2. Type 2. Please take a note of this. Collagen, there is nothing known as collagen ossification. Collagen is the structure or protein which is responsible for the formation of the structure. There are mainly there are two types of collagen: type 1 collagen and type 2 collagen. Type 1 collagen, it is the most important structure, most important protein in the bone. And type 2 collagen, it is the most important thing in the articular cartilage. So I think you understand about the formation of long bones. It is known as ossification. There are only two types of ossification: endochondral, intramembranous. Long bones are formed from endochondral ossification. Flat bones are formed from intramembranous ossification. So in this picture, we can see this is the ossification. just for your better understanding, I keep this picture and option is B, that is a B here. This is mesenchymal cell. So, mesenchymal cell, it is responsible for the formation of flat bones, that is bones of the skull, and the endochondral ossification, that is from the cartilage. It is responsible for the formation of long bones. Okay, please remember, and also you remember about collagen. So next answer is C, hydroxyapatite. Next, white synovial fluid aspirate is an indication of. So, synovial fluid, it is seen in the joint, is it not? Synovial membrane. Inside the synovial membrane, we should understand that there are, what is the normal nature of synovial fluid? So, normal synovial fluid is colorless, or it may be pale yellow in color, or straw colored. So, the question is, white synovial fluid aspirate is an indication of A, increased urate crystal, B, increased cholesterol, C, normal synovial fluid, D, A or C, E, A and B. So we have already told that synovial fluid, the normal synovial fluid is colorless, or it is pale yellow in color. So white synovial fluid is something what? Pathological. And white synovial fluid, it is seen in answer is E, A and B. In case of increased urate crystals and in case of increased cholesterol, white synovial fluid is C. Understand? Increased urate crystals and also increased cholesterol. So next slide will say show what are the different types of synovial fluid. So synovial fluid with associated laboratory findings. This is the one we should be remembering. We are not remembering viscosity also. We should remember the causes, color, and also WBC count. No need of remembering the absolute WBC count. You should remember whether the WBC count is increased or reduced. So, regarding the normal synovial fluid, color is clear. And in Davidson, it is said that sometimes it is straw colored or light yellow colored. So, normal synovial fluid, it is colorless, viscosity is high, and also WBC count is less than 150 cells or 25% neutrophils. 25% neutrophils. Okay. Then, in case of osteoarthritis, we all in case of osteoarthritis, we all joint disease, and in degenerative joint disease, what WBC count will be raised to minimum, only minimum increase in WBC count. Okay, so osteoarthritis, degenerative joint disease, in this the color of the synovial fluid is clear, viscosity is high. Normally, synovial fluid is having high viscosity. So viscosity is high and there is minimum increase of WBC count. Okay, and crystal-induced arthritis. Crystal-induced arthritis includes gout and pseudo-gout. We all know that. And crystal-induced arthritis, what happens is there will be increased neutrophils. Crystal-induced arthritis is an inflammatory type of arthritis. Since the crystals are seen in the joint cavity, there is chance of inflammation. So what happens? There is increase in neutrophils to 5,000 to 50,000. 2,000 to 50,000 per little. So what happens is in crystal-induced arthritis, color changes, viscosity becomes variable, and also the WBC count increases. Next, autoimmune arthritis. Autoimmune, we all know that our body will be what? Producing some agents against our body, autoimmune. So immune agents against our body. It is also a type of inflammatory arthritis. It includes SLE and rheumatoid arthritis. Again, it is cloudy. See, in crystal-induced arthritis and also autoimmune arthritis, which are inflammatory type, the color is cloudy, viscosity is variable, and there is increase in neutrophils. You understand? Normal, there is no increase in neutrophils. In degenerative joint disease such as osteoarthritis, there is minimum increase in neutrophils. In inflammatory arthritis such as crystal-induced arthritis and autoimmune arthritis, there is very much increase in neutrophils. You understand? Next, septic arthritis. So septic arthritis means it is caused by some septic organisms such as Staphylococcus aureus and Neisseria gonorrhoeae. And in case of septic arthritis, septic means pus. You remember like that. So septic arthritis, pus, the color of pus is yellow or green. So in septic arthritis, the color of the synovial fluid is yellow, green or milky. Viscosity becomes low and neutrophils, that is WBC is again increased. Understand? Next, in case of hemorrhage, so there is something known as hemarthrosis, which is caused by hemorrhage into the joint space. In case of hemorrhage, such as it is seen in conditions such as hemophilia and also trauma. What happens is, since there is presence of blood in the synovial fluid, the color of the synovial fluid becomes reddish brown, and nothing about viscosity and WBC count. Understand? So you keep in mind, when there is clear or straw colored synovial fluid, it is normal. And in degenerative joint disease, the color will be normal. There will be minimal increase of neutrophils. But in case of inflammatory arthritis such as crystal-induced arthritis, autoimmune arthritis, septic arthritis, etc., there will be increase in WBC, color will be cloudy, and except in septic arthritis, what happens? There will be production of pus. Pus is yellow or green in color, and the color of the and the color of the what? Synovial fluid is. It will be yellow or green, or milky. You understand? And in case of hemorrhage, what happens? Hemorrhage means there will be bleeding into the joint space. Blood is red in color, and the color of the synovial fluid is reddish brown. You understand? So this is the first investigation which is given in Davidson regarding the rheumatological, this one, rheumatology. So white synovial fluid, it is seen in what? White synovial fluid, it is seen when there is increased urate crystals and increased cholesterol. Okay. Next, fifth question. So we all know about syndesmophytes, is it not? Syndesmophytes. So something known as osteophytes are there, something known as syndesmophytes are there. We all know that ligamental osteophytes are known as syndesmophytes, is it not? So what happens to ligament? Since there is increased inflammation or something, what happens is these ligaments get calcified. And this calcified ligament, that is osteophyte of the ligament, extra calcification. Always osteophytes are extra calcifications, is it not? So when there is extra calcification of the ligaments, it is known as syndesmophytes. And the question is, syndesmophytes are seen in X-ray finding of A. psoriatic arthritis, B. osteoarthritis, C. spondyloarthritis, D, A and C, E, B and C. So the thing is, we have learned many times that syndesmophyte is a characteristic of spondyloarthritis. But according to Davidson 23rd edition, syndesmophyte is seen in psoriatic arthritis also. Very, very important. So syndesmophytes, it is the finding of both psoriatic arthritis and spondyloarthritis. Understand? So answer is A and C. That is D. D is the answer for this question. Syndesmophytes, that is ligamental osteophyte. It is seen in psoriatic arthritis as well as spondyloarthritis. Okay. So this is taken from the Davidson, and this table shows the radiographic abnormalities in selected rheumatic diseases. So, rheumatoid arthritis. So, X-ray finding. We all know that X-ray shows mostly the joints and the bones, is it not? So it is very difficult to identify soft structures. What is the pattern or what is the condition of soft tissues around the joint or around the bone in a case of X-ray? X-ray is very important for joint and bones. So some of the radiographic abnormalities in some rheumatic disorders in Davidson, it is explained like this. So in rheumatoid arthritis, we all know that rheumatoid arthritis is inflammation. So what happens? There will be joint space narrowing will be there. Due to inflammation, there will be marginal joint erosions. This is the things which we can see in X-ray. In rheumatoid arthritis, there will be periarticular osteoporosis. Periarticular means around the joint. Periarticular osteoporosis, joint subluxation. What is subluxation? That is partial dislocation. So it will be affecting the tendons, that cartilage, whatnot. Everything it will be affecting. So periarticular osteoporosis, joint subluxation will be there, marginal joint erosions will be there, and also joint space narrowing will be there. In case of rheumatoid arthritis, in case of osteoporosis, in osteoporosis, what is happening? There is reduced bone mineral density, is it not? So in osteoporosis, there will be osteopenia, vertebral fractures, non-vertebral fractures, and also cortical thinning. Since there is reduced BMD, there is cortical thinning. And in case of Paget's disease, what happens? In Paget's disease, there is bone expansion, abnormal trabecular pattern. What is trabecular? This collagen in bones, this collagen is thickly packed as a meshwork. Okay, so what happens is in Paget's disease, what happens is this trabecula or this thickly packed collagen collapses, leading to abnormal trabecular pattern. So in Paget's disease, in X-ray, we can identify bone expansion, abnormal trabecular pattern, osteosclerosis and lysis, that's its destruction of the bone, and also pseudofractures. Very, very important. Pseudofractures, it is seen in Paget's disease. Then psoriatic arthritis. In psoriatic arthritis, there is sacroiliitis, proliferative enthesis erosions. Enthesis we all know, no? Where the bone joins the muscle or tendon. It is known as proliferative enthesis. Sorry, it is known as enthesis. And in case of psoriatic arthritis, there is proliferative enthesis erosions. Then there is syndesmophytes. This is what we have seen in previous question. Syndesmophyte. It is seen in not only in spondyloarthritis, it is seen in psoriatic arthritis also. So there is syndesmophytes. Then there is enthesophytes. What is enthesophytes? Calcification of the enthesis. Calcification of the enthesis means the junction where this tendon joins with the bone. Enthesophytes. Then there is bone sclerosis and also juxta-articular new bone will be there. Then osteoarthritis. What is osteoarthritis? We all know that it is a degenerative disease. In degenerative disease, there will be joint space narrowing. So you see joint space narrowing, it is in rheumatoid arthritis and also OA. So joint space narrowing, there will be osteophytes. So osteophytes is the character of osteoarthritis. Syndesmophyte is the characteristic of what? Psoriatic arthritis and also spondyloarthritis. So osteoarthritis joint space narrowing, osteophytes, subchondral sclerosis, joint deformity, and also presence of subchondral cyst. So this is what is explained in the Davidson. And the answer for our previous question, syndesmophytes are seen X-ray finding of psoriatic arthritis and also spondyloarthritis. Next, BMD. What is BMD? Bone mineral density. Bone mineral density is measured using A, X-ray, B, CT. CT means computed tomography. C, DXA, dual X-ray absorptiometry. In KVK and other textbook, it is seen as DEXA, dual energy X-ray absorptiometry. But in Davidson, it is given as DXA. So dual X-ray absorptiometry, and D is MRI, magnetic resonance imaging. So the question is, BMD, what is the importance, how we can measure BMD, and which investigation help us to measure BMD, bone mineral density? So answer is C, DEXA, dual X-ray absorptiometry helps in what? Helps in the measurement of BMD. So already we have told about X-ray. Regarding X-ray, X-ray is very useful in the seeing joint and bone joint and bone. CT, computer tomography, it is also very important in case of bone and joint. So much of bones and joint pathology can be identified in CT than X-ray. And regarding MRI, it is very, very important. Three-dimensional pictures can be collected by means of MRI. MRI helps not only in the identification of bones and joints, it also helps in the identification of soft tissues. This disc spaces in about the intervertebral disc and all, MRI is very, very important. And regarding DEXA, DEXA is very, very important in BMD. DEXA is the thing which is helps. And the answer is DEXA, DXA, dual X-ray absorptiometry. It is used in measuring BMD. So this slide show you, this is the picture which is given in Davidson. Okay. So this is the way how BMD is measured. This is dual X-ray absorptiometry and it will be measuring the BMD. And please take note of this normal BMD. BMD is measured by using T-score. You can see here. This is T-score. When the bone mineral density is between -1 and 2.5, -1 and 2.5 plus 2.5, -1 and plus 2.5, BMD is normal. T-score is between -1 and plus 2.5, BMD is normal. And when it is minus 2.5 or below, when it is minus 2.5 or below, it is known as osteoporosis. Osteoporosis, we all know that. What is osteoporosis? There will be reduction in bone mineral density leading to fractures. So this bone mineral density in case of osteoporosis, it is between minus 2.5 or below. Minus 2.5 or below. And when it is between -1 and -2.5, it is known as osteopenia. Osteopenia. So -1 and -2.5, it is osteopenia. -2.5 and below, it is osteoporosis. And if it is between -1 and plus 2.5, BMD is normal. You understand? This is the importance of BMD. Then next question. So we are dealing about the investigations, important investigations, and the intuition or the thing which I have to say you, or which I want to share with you is you should not miss anything in Davidson. You should go through every pages of Davidson. So it is very difficult for you go through. Only PM is not the only subject you have to study. That's why I have gone through every line of Davidson and I prepared some MCQs so that you will be having a confidence that you have seen all the pages of Davidson, you have read all the pages of Davidson. Okay. So what I am saying is very, very important. And along with that, I am explaining the other things also so that you will be having a confidence while writing the exam. Next question. Levels of calcium and phosphate is normal. See, at first we have said that calcium and phosphate is the most important mineral as far as the bone and teeth is concerned. And it is deposited in the bone in the name of hydroxyapatite, is it not? So now the question is levels of calcium and phosphate, serum calcium and phosphate, okay, in blood. So levels of calcium and phosphate is normal in A, osteoporosis, B, renal osteodystrophy, C, primary hyperparathyroidism, and D, hypophosphatemic rickets. Can you guess? Levels of calcium and phosphate is normal in, and it is normal in osteoporosis. So we will be thinking that osteoporosis is reduced bone mineral density. So that what happens? There will be reduced calcium in the blood. No. In osteoporosis, since why there is reduction in bone mineral density? Due to the hormonal issues, is it not? It is most common in females. Estrogens. Due to in menopausal females, due to deficiency of estrogen, there will be resorption of calcium from calcium and a phosphate from the bones. But there will be resorption of calcium and phosphate from the bones. But what happens in the serum or in the blood? Calcium and phosphate is normal. You understand? In renal osteodystrophy, it is not normal. Primary hyperparathyroidism, no. Hypophosphatemic rickets, again, no. But it is normal in case of osteoporosis. So we will see another table. This is also I have taken from Davidson. See, this table depicts typical biochemical abnormalities in various skeletal disorders in serum. Okay, in serum. That is in blood. In blood. So, see, we will see it one by one. In case of osteoporosis, very, very important. Please just you listen. In osteoporosis, calcium is normal, phosphate is normal, and alkaline phosphate is ALP. It is normal but increased in fracture. Parathyroid hormone normal or increased, and you leave this, and you leave this also. Vitamin D, it is normal or reduced. You be careful with these three things. Okay, osteoporosis, calcium and phosphate is normal, ALP is normal or increased after fracture. Then Paget's disease. So we have said no, Paget's disease, the trabeculae will change, the what volume of the bone will get increased. So in Paget's disease also calcium and phosphate is normal, but there due to increased turnover of the bones, this ALP will be increased when there is increased turnover of the bones. Paget's disease, there is increased lysis of the bone, is it not? So metabolism of the bone is getting so much of increase, and what happens? The trabeculae gets distorted. So in Paget's disease, metabolism of the bone increases and ALP will be increased. Then next, in case of renal osteodystrophy, what happens? Renal means kidney, osteo means we all know bone, dystrophy is or destruction. So renal osteodystrophy, calcium will be normal or reduced, phosphate will be normal or increased, and ALP is slightly increased. In case of Paget's disease, what happens? As I told earlier, there will be increased metabolism of the bone, and there will be so much increase of alkaline of the ALP. But in case of renal osteodystrophy, there will be slight increase. Okay. Next is vitamin D deficient osteomalacia. Calcium is normal or reduced. Why? Vitamin D, it is an important thing. It acts as an enzyme, is it not? It acts as an enzyme for the absorption of calcium from the gut. So when there is reduced vitamin D, what happens? Calcium, there is chance of reduction of calcium. Phosphate also chance of reduction, and ALP is slightly increased. Then hypophosphatemic rickets. The name itself says hypophosphatemia. There is reduced phosphate. So phosphate is very much reduced, but calcium is not. Okay. Rickets, vitamin D only. It is due to reduction in vitamin D. Okay. So normal, and ALP is slightly increased. In primary hyperparathyroidism, we all know that parathyroid hormone, parathormone. What it do? It increases the resorption of calcium from the bones. As a result of that, what calcium will be increased so much. Understand? So primary hyperparathyroidism, there will be so much of increase in calcium, normal or reduced phosphate, and normal or increased ALP. Understand? So you see all these things, normal, Paget's disease and osteoporosis. We think that osteoporosis, there is bone mineral density, so there will be reduced calcium. No, in osteoporosis, bone mineral density is reduced, but serum calcium and phosphate is normal. Paget's disease, we think that, oh, there is increased turnover of bones, so there will be reduced calcium. No, in Paget's disease, calcium and phosphate is normal. And also in hyperphosphatemic rickets, there is normal calcium. Primary hyperparathyroidism, calcium may be increased more due to more resorption of the bones. So next, so this is another type of question, which the trend of this type of questions are more latest Aiapget, is it not? So which of the following statement is or correct? One, CRP is rise. What is CRP? C-reactive protein. So it is why it is known? What is the full form of C? It is capsule. Why it is known as C-reactive protein? It is first identified in the capsule that a protein which reacts with the capsule of a bacteria known as pneumococcus. Okay, so it is known as CRP. C stands for capsule of pneumococcus. So first one is CRP is raised in all inflammatory, infective, and autoimmune connective disease. So C-reactive protein in this statement says that CRP is increased in all conditions such as inflammatory, infective, and autoimmune disease. Second statement says that CRP is more specific than ESR in infection and inflammation. this statement is saying ESR. CRP is what? More important than ESR in finding out infection and inflammation. Third statement, CRP and ESR is raised in autoimmune connective tissue diseases like SLE and PSS. So this statement is saying that both CRP and ESR will be increased in autoimmune diseases. SLE means systemic lupus erythematosus. What is ESR? ESR is erythrocyte sedimentation rate. SLE is systemic lupus erythematosus. PSS is progressive systemic sclerosis. And the fourth statement says that CRP is normal and ESR is raised in autoimmune connective tissue diseases like SLE and PSS. Be very careful. The question is which of the statement is or correct. So one or two statements will be correct here and some will be wrong. So we will see which is the correct answer. So the first correct answer is, first one is CRP is more specific than ESR in infection and inflammation. Before the ESR starts rising, CRP will be increased. You understand? So CRP, that is correct. Then second statement which is correct is CRP is normal and ESR is raised in autoimmune connective tissue diseases like SLE and PSS. So CRP will be normal in that condition and ESR is raised in that condition. You understand? So now we will check the other thing. CRP, first one you see, CRP is raised in all inflammatory, infectious, and autoimmune connective disease. No, why? The fourth statement is correct, is it not? It is normal and ESR is raised in autoimmune connective tissue disease. The first statement says that CRP is raised in autoimmune connective tissue disease. No, so it is wrong. And third statement, CRP and ESR is raised in autoimmune connective disease. No, CRP is normal and ESR is raised in autoimmune connective tissue diseases like SLE and PSS. So which are the statements correct? 2 and 4. 2 and 4. The option is C. You understand? So regarding CRP, CRP is raised in inflammatory and infective disease and autoimmune connective disease. It is not raised. CRP is superior to ESR. But in autoimmune connective diseases, ESR is superior to CRP. You understand? And the answer is 2 and 4. That is, answer is C. Okay. Next. Ninth question. Dash can be detected in asymptomatic patients several years before the development of RA. RA is rheumatoid arthritis. We all know that rheumatoid arthritis is an autoimmune disease. It is an inflammatory disease. There will be production of so much of deformity, which is very difficult to bring back to normal. Is it not? So, Dash can be detected in asymptomatic patients several years before the development of RA. The thing the question says is, which is the most sensitive test? Where what sensitive test where RA can be diagnosed. Sensitivity means true positives, is it not? So Dash can be detected in asymptomatic patients. So first is RF, that is rheumatoid factor. B, CRP, C-reactive protein. C is ANCA, ANCA, anti-neutrophilic cytoplasmic antibodies. Anti-neutrophilic cytoplasmic antibodies. And ACPA, that is anti-citrullinated peptide antibodies. Okay. Anti-citrullinated peptide antibodies. So which is increased. So regarding the rheumatoid factor, it shows positive in RA patients. But once the RA is established, it shows the severity of this disease. Understand? So RA will be positive once the symptoms are produced. Second, CRP. CRP will be increased in rheumatoid arthritis. But what happens? CRP is, we cannot identify persons who are prone to RA by means of CRP. And also regarding RF, rheumatoid factor, we cannot identify patients who are prone for RA who is having positive RF. Okay. Then regarding ANCA, ANCA. ANCA, whether it is specific for rheumatoid arthritis? No, it is specific for vasculitis. When there is inflammation of small blood vessels, ANCA will be positive. There are two types of ANCA. We know C ANCA and P ANCA. It is of not importance since MCQ is concerned. ANCA is, keep in mind, ANCA, it is positive in vasculitis. RF, it is positive in RA. CRP, all infective and inflammatory condition except autoimmune diseases like connective tissue diseases like SLE and PSS. And the ACPA, anti-citrullinated peptide antibodies, and it is the diagnostic, and it is more specific than, more sensitive than RF in diagnosing RA. Okay. ACPA, anti-citrullinated peptide antibodies, it is more specific in identifying RA for those who are prone for RA before the production of symptoms, before the patient knows that I am having some joint pain, before the patient knows that I am having some joint immobility or what, early morning stiffness, before the patient understands that I am going for RA, what happens? ACPA will be positive. You understand? So it is a good predictor of RA, and the answer is ACPA. Rheumatoid factor is, of course, it is seen in rheumatoid arthritis, but it is not an early predictor of RA. CRP, it is raised in infective and inflammatory, but it is not an early predictor of RA. ANCA, it is positive in vasculitis. It is not an early predictor of RA, but ACPA, it is an early predictor of RA, and it can be identified in asymptomatic patients several years before the development of RA. You understand? Answer is D. Yes. ACPA. ANCA is positive in what? Is vasculitis. Then, so we are traveling through Davidson Rheumatology chapter. Okay. Connective tissue and joint diseases, musculoskeletal and joint disorders. We are traveling through the chapter. We are having a cut section of the chapter of rheumatology in Davidson. We have completed the basic anatomy, physiology, different types of bones, different types of ossifications, etc. Then we come to the investigations. We have traveled through all the investigations what Davidson have said, like synovial fluid analysis, X-ray, CT, MRI, DXA, then biochemistry, ANA, ANCA, and also ANA. I forgot to say about ANA. It is positive in spondyloarthritis, autoimmune spondyloarthritis. It is positive, and also autoimmune diseases, it is positive, such as Sjogren's syndrome and anti-nuclear antibody. Okay, antibody, autoimmune disease. So we have traveled through the investigations. Now we have reached a point where investigation got over, and we are going to the next session of Davidson, that is symptomatology, presenting complaints of musculoskeletal diseases. Okay. So the first presenting symptom is monoarthritis, acute monoarthritis. So the question is, which of the following is the less common cause of acute monoarthritis? We all know that acute means sudden onset. It has a brisk course. Monoarthritis, it is affecting a single joint. Arthritis means inflammation of the joint. So, sorry. Monoarthritis means inflammation of a single joint. And the question is, which is the less common cause? So we should know what are the causes of monoarthritis. Is it not first? So we will see. A, leukemia, B, gout, C, pseudogout, and D, reactive arthritis. What is leukemia? It is a type of cancer. Cancer of blood, white blood cells is leukemia. Second is gout. Gout, we have been studying from the second question onwards. Gout is crystal-induced arthritis. It is an inflammatory arthritis. In inflammatory arthritis like gout, what happens in synovial fluid? Neutrophils will be increased, WBC will be increased, color will be cloudy, and all we have explained. And gout, it is a crystal arthritis. Pseudogout, calcium pyrophosphate. In gout, what happens? There will be deposition of uric acid, but in case of pseudogout, there will be deposition of calcium pyrophosphate. And D is reactive arthritis. Reactive arthritis means what? Is some reaction. In case of what? Something is happening in our body, and in reaction to that, our joint is getting inflamed. That is reactive arthritis. Some intestinal diseases. We know about enteropathic arthritis, Whipple's disease, etc. It produces reactive arthritis. In reaction to some other disease, the body is producing arthritis. some other disease is there, what happens? Arthritis is produced. You understand? So with regard to this, we know about Ponset syndrome and all, is it not? PONCETS. Ponset syndrome, what is happened? There is some disease and it is producing arthritis. What is that disease? It is tuberculosis. Okay, you leave that. Ponset syndrome, it is in TB. We'll explain later. So reactive arthritis, there is some disease process going on in our body and it is producing monoarthritis. So the question is, which of the following is less common cause of acute monoarthritis? And the answer is leukemia. So leukemia, gout, pseudogout, and reactive arthritis, it is the most important cause of most common cause of monoarthritis. Leukemia in children, leukemia will be producing as monoarthritis. Leukemia produces monoarthritis in some children. Okay, so leukemia, it is the less common cause of acute monoarthritis. So again, we will go to a table of Davidson. See, causes of acute monoarthritis. So he have divided in this book the acute monoarthritis. The cause is divided into two. One is common, that is regularly we used to have. That is, if there is this disease, the person will be producing the acute monoarthritis. Next is less common cause. What is meant by less common cause? If the patient is having this type of diseases, there is what? Rare chance of getting acute monoarthritis. It will produce polyarthritis, means there will be involvement of more than 5 joints or something, but it is very rarely producing acute monoarthritis. So causes of acute monoarthritis, common causes are gout, crystal induced arthritis, and the most important area where gout affects is first metatarsophalangeal joint. Okay, very important. Gout, it affects, so it is a common cause of acute monoarthritis. That is, it will be affecting a single joint, and the most important site in gout is what? Is first metatarsophalangeal joints. Next is pseudogout. Pseudogout, we all know that it is deposition of another crystal known as calcium pyrophosphate, and pseudogout, it is seen in wrist and ankles. Okay. Next, trauma. Yes, trauma. If you have a fall or if you have a road traffic accident, one of our joint will be getting swelling, pain due to injury. Next, hemarthrosis. What is hemarthrosis? There will be bleeding inside the joint, and the most important site to be affected with hemarthrosis is knee joint. Okay. So gout, pseudogout, trauma, hemarthrosis. Next is spondyloarthritis. Spondyloarthritis, we all know that it is an autoimmune disease where HLA-B27 is positive. HLA, human leukocyte antigen B, is positive. Next is psoriatic arthritis, which is associated with psoriasis. So we have seen psoriatic arthritis and spondyloarthritis. There is what? Presence of syndesmophytes in X-ray. You don't forget that. Okay. Next, reactive arthritis. Next is enteropathic arthritis. So these are the common causes of acute monoarthritis: gout, pseudogout, trauma, hemarthrosis, spondyloarthritis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. Next, less common causes of acute monoarthritis. One is rheumatoid arthritis. It is not affecting a single joint. It is symmetrical joint affection. Next, tuberculosis. Tuberculosis known as Ponset syndrome. Juvenile idiopathic arthritis. It will be affecting more joints. Polyarthritis. Next, leukemia. Then pigmented villonodular synovitis, gonococcal infection, osteomyelitis, foreign body reaction. So these are the less common causes of acute monoarthritis. So you identify or you study the common causes. When you know about the common cause of acute monoarthritis, it is easy to identify the less common causes. You understand? So common cause, it is very, you just understand gout, pseudogout, trauma. You just identify the pathology also. Gout, pseudogout, trauma, hemarthrosis, spondyloarthritis, psoriatic arthritis, reactive arthritis, enteropathic arthritis. These are the common cause of acute monoarthritis. So in the last question, everything is there. Gout, pseudogout, reactive arthritis, leukemia is the only odd thing, and the answer is leukemia. Understand? So we have covered the first symptomatology of rheumatology in Davidson, that is acute monoarthritis. So Now we will stop the session. In the next session we will continue like this. If you have any doubts or something, you may please contact Dr. Regine and I will be giving you the correct answers. And if you have want any modification of the class, you please say to him so that I will be knowing and we can modify like that. Sorry for the interruption due to this internet issues. So I hope this class is useful to you. Thank you for your patient listening. Once again, I thank Dr. Regine for giving me this wonderful opportunity. Thank you.
Thank you.
Thank you. So the first question is osteoclast R. So for osteoclast, option A is derived from the cancellous bone